everybody. My name is Alice Tunks. I'm a PhD researcher at Brighton and Sussex Medical School, and I'm based within the primary care department and public health department. Sorry. Thank you for listening to this presentation. If you are, sorry I can't be there. I'm away at the moment. But yeah, it's thank you for the opportunity, the ARC, for this opportunity to present this work. It's really lovely to be able to share with you a little bit about my PhD, and yeah, give a bit of an overview of what my poster was about. This is a work in progress, so yeah, the results aren't quite there. I'm still recruiting and still developing ideas around it. But yeah, this is just an initial kind of presentation. But yeah, this research looks at, it's a qualitative study looking at barriers and facilitators to accessing evidence-based psychological treatment for perinatal OCD, which I'll come on to in just a moment. The project's called the Open Door Project. If you want to follow us on social media, we've got Instagram, Twitter, Facebook. And my supervisors are Liz Ford, Cleoberry and Clara Strauss. So just as a bit of background about perinatal OCD, so the word perinatal is used to refer to the time during pregnancy and then up to the year afterwards. And OCD, which you are most likely aware of, obsessive compulsive disorder, is essentially made up of two components, the obsessions and the compulsions, which I'll come on to in just a moment. In terms of the obsessions, those tend to be intrusive thoughts, and now about 90% of the population, of the general population, experience intrusive thoughts. So kind of typical things are, if you stood at a train station, you think, oh, I could jump in front of this train, or I could push that first person in front of the train. Or if you're kind of chopping up some food, you think, oh, I could just chop off my finger right now. So those are sort of intrusive thoughts. They pop into your head. They don't really mean anything. They just kind of happen. But when somebody starts to develop OCD, those thoughts tend to be given a lot more weight and a lot more meaning. And then that can, obviously cause quite a lot of anxiety. If you think, well, maybe I'm capable of doing that, maybe I want to do that, and that can be really, really distressing. And then that leads to the compulsion, so the C in OCD. And so that can be either physical behaviour or different mental acts, which are ways of kind of reducing that anxiety. In terms of prevalence of POCD, POCD is perinatal obsessive compulsive disorder, in the population, there's really kind of varied estimations around what this could be. So anywhere between kind of 2 to 22%, so between 1 in 50 or 1 in 5 new parents experiencing that. And there's suggestion that actually non-birth parents experience POCD at similar rates to birth parents. So that actually the research suggests that it's a more cognitive behavioural model in terms of how it develops, rather than it being maybe biological. So in the obsessions and compulsions within POCD are most commonly around harm and contamination. So the obsession being around harm, either deliberately or accidentally coming to the child, and then that leading to compulsions of either checking or avoiding behaviour. So for example, a intrusive thought around dropping the baby downstairs can lead to avoidance behaviour, so maybe you never go upstairs with your baby. And then the second type of most common intrusions and compulsions are around contamination and cleaning. So the intrusive thought being around, bacteria or a virus or dirt coming to the child and making them unwell, and then that resulting in compulsive cleaning. So cleaning things all the time. It may, and then as this is in the next bullet point, it can take up a significant part of your day. So on an average, 9.6 hours of a parent's day is taken up by this. So that's a really huge part of your waking day. And that has really significant impacts on kind of obviously the individual's confidence, but also their kind of social relationships, their relationship with their partner, as well as influencing the relationship with their child and kind of those interactions and potentially influencing child development. So it is really, really significant. However, we do have effective treatment. We are aware of that. So that includes antidepressants, SSRIs, which, are shown to be effective, but are sometimes individuals are resistant to that, because if they're breastfeeding or if they are pregnant, there is concerns that this could pass on to the child and kind of, the complexities of that. And then the other type of treatment is cognitive behavioural therapy with exposure response prevention, so CBT with ERP. And so that's been found to be effective in this population. However, so we kind of know a bit about what POCD is, and we know that there's effective treatment, but how exactly do we get people to treatment? And that's kind of where this project fits in. So that's kind of where the idea of what does it mean to access services comes in. So accesses can be a really, really broad term. So it can look at everything from an individual recognising symptoms to them recognising there may be a service or something which could support those symptoms, to all of those initial interactions. So booking a appointment, getting to your GP, those initial interactions with the GP, how you disclose the information around the symptoms you're experiencing. And then on to kind of the more treatment side of things, so getting referral onto treatment, the wait time for treatment, different appointments, can you get to the appointment, can you book the time off work? And then, of course, the actual content of the treatment. So is it appropriate? Does it speak to you? Do you respond to it? And then the outcome. So are you satisfied with it? So the idea of access is really, really broad. And this project kind of fits slightly earlier in the access timeline, so less linked to the treatment, but more linked to, awareness and symptom recognition, and then those initial interactions with healthcare professionals and what influences that. And that's really important in this perinatal population because they have really quite a lot of interactions within primary care. So, they might talk to their GP a fair amount. They have regular visits from health visitors and midwives throughout their pregnancy and the year after pregnancy. However, there is misrecognition of POCD. So sometimes this could be misrecognized as depression, and so parents could maybe, because depression is something that's very well recognised, I suppose, and so parents could be sent onto the wrong kind of CBT course for depression, or alternatively, the intrusive thoughts could be kind of almost ringing alarm bells for healthcare professionals, and then it causes them to get in contact with social services and potentially limit the parents' access to the child, which obviously has significant negative impacts on everybody included. So yeah, that recognition of healthcare professionals is really important, but similarly important is the relationship that the healthcare professional has with the parent. So having trust in that relationship is really important so that the parent feels able to disclose, as well as having kind of continuity of care, so developing that relationship over time, and so the healthcare professional can start to kind of recognise any changes in the parent. So that's a little bit about what POCD is. Hopefully that kind of gives you a bit of background. And then in terms of what this project really, or this study looks at is, so the aim is to develop an understanding, the barriers and facilitators of accessing psychological support for POCD from a service user perspective. So we're interviewing parents who've experienced POCD, who either have or haven't accessed services. So the inclusion of those who haven't accessed services because I think that's really, really important, because, well, what happened? Why didn't they get to services? And I think that's really, really crucial. And also we're sampling those who self-identify, so they don't need to have a formal diagnosis because it's so misrecognised and underdiagnosed. Individuals can self-identify as having experienced it. They need to live in England, and they need to have experienced symptoms during or after 2008, and that's because of the IAP service, which was introduced in 2008 and is only based in England, and kind of changed, I guess, the landscape of access to psychological therapies. In terms of the method, there's this semi-structured interviews, and we're doing reflexive thematic analysis for that. Now, just to touch on the co-production, which is, I guess, well, I mean, I think it's all quite exciting, but this is one of the bigger exciting parts of the project. So when I selected the population of perinatal OCD, I then recruited 5 experts by experience. So there's 5 mums who experienced perinatal OCD and kind of wanted to get involved within research. And they've been involved right from when was August, September last year, when I started developing the ethics application for this study. So they were involved in all the co-creation of the participant-facing materials, so things like the recruitment poster, the topic guide, the debrief thing, all of these different types of things. They involved in all of that, and they were really, really helpful, informative, and brilliant. And I learned so much. So things that I maybe wouldn't even question, they questioned. They were saying, oh, we shouldn't word it like this, or maybe we could put this into it. And it's just been absolutely invaluable to have them included. 3 of them have now been and are kind of, I'm doing a bit of a follow-up training to conduct interviews. And so they'll be doing those over the upcoming weeks. So involving experts by experience in peer interviews, I think, is going to be really interesting, and I'm hoping to learn some things which will be good. And then all of them will be trained up to do some thematic analysis. They'll all be involved in looking at the different sub-themes and themes and the quotes. and yeah, discussing the ideas around them. And then crucially, they will be involved in creating the dissemination plan. So the kind of impact and dissemination of this project is really, really important, and getting the word out there, especially because awareness with perinatal OCD is so low. So yeah, awareness and dissemination is a really big part. So yes, they'll be involved in that quite heavily. In terms of how we've kind of gone about co-producing, so I've essentially used the NIHR involved guidelines. So those include the idea of like sharing power and valuing others' knowledge, as well as flexibility. And flexibility has had to come in, you know, working with parents who have young children, you know, flexibility is absolutely crucial. And really valuing their knowledge. So remuneration has been really, really important, and making sure they get paid on time, ideally. And then crucially, big thing is to move away from the us versus them discourse, so the healthcare professional and the patient discourse, and especially away from the unwell patient discourse. So a lot of parents, or the mums I've been working with, very often their motivation seems to be that they didn't necessarily have the most positive experience, but they want to turn that into a positive experience. So they want to try as best they can to ensure that no other parent will go through the same things that they did. So this is kind of their way of kind of becoming more empowered to try and do that. And I think that's it's brilliant for them, and also it really benefits this project. So now just some preliminary results. So these are, very much so preliminary. They're not, they will probably change quite a lot over time. But yeah, there's just 4 initial ideas that were coming out. I thought it would be interesting to present them. So the first one, if you don't fit in the perinatal or the postnatal depression box, then ... So the idea is around, well, individuals got the impression that healthcare professionals felt like, well, we know about postnatal depression, we can deal with that, we know where to refer you on to, we know what it looks like, we know what to do with it. However, if you've got something else, I'm not really sure what we can do. And so kind of feeling at a bit of a loss that, well, I don't have depression, so I can't really get support. And that kind of, lack of, I guess, appropriateness of services, really. So the quote here says, it was almost like, if you haven't got postnatal depression, then what do we do? Then the second theme is around, I'll just deal with it. So obviously when somebody becomes a parent, their priorities, their responsibilities completely change. You know, somebody else is your number one. And very often this seemed to then result in, when parents were experiencing these anxieties and symptoms, they would just kind of brush them to one side and go, well, actually, that's not my priority. It's not impacting other people. And you know, it's my problem, and it's not anybody else's problem, and therefore I shouldn't actually be getting any, maybe not quite, I shouldn't actually be getting any support, but it's not a priority to be getting support. So that's kind of what we're saying here. So in this quote, it says, it was just something that I was like happy to take responsibility for. I felt like it wasn't affecting my baby. The consequences of these thoughts were my own anxiety. So I just thought it's my responsibility and it's my problem if I choose to seek help or not. So yeah, a lot of, I guess, kind of awareness and understanding and responsibility ideas coming in there. Then the third idea is around whether treatment is appropriate. So this kind of talked about in 2 folds of those who hadn't accessed treatment, considering whether, you know, well, what can services really offer me? Is there actually going to be anything that useful? And is it going to be worth my time? Essentially, obviously, new parents, very busy, babies take up a lot of time. Is it going to be worth me going to that? And then sometimes those who did actually go to services found that maybe the treatment being offered wasn't that appropriate. So maybe it wasn't actually that geared towards a perinatal population. The ideas around the obsessions and compulsions weren't actually linked to children. So questioning whether treatment was the best. The quote here says, but it's when it comes to the actual kind of intervention side, I just think, well, it's more, I just don't really feel like there's that much that can be done. Then the final theme, I guess we could call them, is when do mum anxieties become POCD? So obviously the obsessions that can kind of occur within POCD, a lot of mums may kind of experience anxiety. So, you know, every mum would probably be concerned around harm coming to their child, or around, contamination or the child getting ill and things like that. So it's quite, I guess, common to experience some level of anxiety. But both the parents who I've spoken to, as well as their perception of the healthcare professionals, were not quite sure when that anxiety and typical mum or expectable mum anxieties then flipped over into more kind of POCD-like symptoms. So that kind of distinction and awareness around when maybe it was becoming something that needed to be supported wasn't quite understood. And then that, as you'll see in the quote, that kind of then comes with a lot of stigma and shame and blame, because, you know, well, what's wrong with me, essentially. So the quote here says, the whole time I was asking for that help, I was like blaming myself for things. This is just me not coping with the anxieties of pregnancy, and everyone feels like this, but they've got much better coping mechanisms. So those are just 4 initial ideas around what this project has kind of found so far. Going forward, the results from this will be used to inform a toolbox design. So we'll take the results and prioritise the different kind of barriers and facilitators alongside healthcare professionals, and then we will kind of co-design those into an idea of best practice. So yes, that's everything from me. There are also some references on there if anybody would like them. But yes, thank you very much for having given me 15 minutes of your time, and I hope you have a really lovely rest of the research this week.